This has been a moving target, the utility of spinal fluid biomarkers. Back in the mid to late 1990s, there was a paper that came out saying the 14-3-3 protein had, I think at that time they said 100% sensitivity and high 90% specificity. And we found very different results. And we think that that's a much less specific protein, and we find it elevated in many other conditions. So there's the 14-3-3 is a protein that's been used, the total tau protein, neuron-specific enolase. Those are probably among the three most common that have been used diagnostically, and it does vary from country to country. The RT-QuIC has been around for about over 10, 15 years now, started in research, and basically it's a PCR for proteins, and it's a amplification of misfolded proteins into amyloid fibers. If there are prions or misfolded proteins present in your sample, they could indicate disease. So there might be misfolded prion proteins, alpha-synuclein, tau, amyloid. You can amplify them by either sonicating or shaking the substitute. So you take your sample that might have the misfolded protein, and then you take a substrate that has normal protein, and you put them together and you sonicate or shake them, and if the abnormal proteins were present, they should begin to transform the normal-shaped ones into misfolded ones, and you'll get amyloid fibers. Amyloid binds thioflavin, which can fluoresce, and you can get a fluorescent signal in your test if the prions if the misfolded proteins were present. And that test seems to be quite good. The specificity is probably greater than 98%. Some people say 100% specificity. I never believe 100%. There are always false positives. We certainly had some false positives early on. They're less common now that the test has improved. And then the sensitivity has been reported as high 90 percentile. In our cohort, it's lower. It's in the 80 to 85 percentile. So a positive test in the right clinical scenario for this assay called the RT-QuIC, which stands for reverse templating quake-induced conversion assay. And the RT-QuIC in our hands is about 85% sensitive. So a positive test with very high specificity means something in the right clinical scenario. If you don't have the right clinical scenario, you don't have a patient with rapid neurologic decline, it's not even useful to send the test. But a negative test to us doesn't mean anything because they could still have it, because at least 15% of patients who even have prion disease will still have a negative test. And in those cases, we might repeat the test because there has been data showing that if you repeat it, some of those patients who are initially negative will eventually become positive. So I think this test has really helped us diagnose patients. And it's now used in some criteria. To me, I find that it's a helpful supportive test, but some of the criteria from the US CDC, the Europeans, they will allow a probable diagnosis if you have any progressive neuropsychiatric condition and a positive RT-QuIC from any tissue. I'm a little bit more conservative, and to me, it has to be a progressive neuropsychiatric condition that is consistent with prion disease. And then in most cases, given that the MRI can have high 90% sensitivity, I usually like the MRI to be consistent. But MRI is not 100% sensitive. We know about 5% of patients or less will not have a positive MRI, or maybe their MRI is just not good enough quality. So in those cases, maybe the RT-QuIC would be helpful.